All right, thanks. Okay, grateful to be here. Thanks to the SMSNA. Thanks to the session moderators for this opportunity. Who in the audience uses Verapamil to treat patients with Peyronie's? Okay, all right. So I got my work cut out for me because it's definitely not the majority, but we'll see what we can do here. So I certainly use Verapamil in my practice. I think it's alive and well, and I'll talk to you about why the spirit of interferon lives on as well. So my disclosure is that I receive research funding, and I'm a consultant for Endo and sit on the board of directors. And I do want to acknowledge that we up here are really standing on the shoulders of giants. These are just some examples of some of what I would call the godfathers of Peyronie's disease, especially intralesional therapy. So currently interferon is not available, so most of the focus is on Verapamil, but we're going to say for Dr. Hellstrom and others, the legacy of interferon lives on. So this is the typical treatment paradigm for patients with Peyronie's disease, and I think we should be counseling patients about all of these options and just acknowledging that this is not a one-size-fits-all approach. This is a shared decision-making. Not every patient with Peyronie's disease meets the criteria and should be considered a candidate for each of these treatments. I certainly am a big proponent for surgical straightening. There's no more rapid and reliable way to get that penis as close to aerostraight as possible. But remember, many of the patients that come into the office may not yet be candidates. Maybe they're still in the active phase. Their predominant symptom is pain. Maybe they want to approach this in a more stepwise fashion. And maybe they'll never entertain the idea of surgery. Keep that knife away from my penis. So with that in mind, intralesional therapy is really a mainstay treatment. And over the last decade, we've seen a significant rise in the primary treatment being intralesional therapy. And Dr. Mills has done a great job of talking about this FDA-approved collagenase. But remember, the AUA guideline, and Dr. Mills points this out very well, the AUA guideline says we have 3 options to consider for intralesional therapy. Really 2 now, but again, for historical purposes, 3 options available. And yes, the data is less robust when it comes to intralesional injections with Verapamil because of the lack of industry funding. And yes, the literature is more heterogeneous with the powering of the studies and the clinical protocols. But I think in that setting and just in general with what we do, it's okay to put more emphasis on clinical series and subjective outcomes. If you look at some of the clinical series that have been published, we see significant reductions in curvature reported objectively and subjectively in up to 2/3 of patients, some studies showing an average of 15 and up to 30 degrees of curve reduction. Even at this meeting, Dr. Campbell and colleagues showed us their multi-institutional data of 234 patients treated in Canada where collagenase isn't available, and 81% of those patients reported subjective improvement in their curvature. So yes, that's not objective data with curve assessments, but remember, a lot of the objective curvature data that we're relying on is subject to error. We have a goniometer, we have an erect penis, and those can vary. We can place the goniometer slightly different and get a 10, 15, even 20 degree difference, which is within the margin of error of what we're talking about when we're comparing intralesional therapies. The other thing to keep in mind is that we aren't doing this as monotherapy in the modern era. Even with collagenase, other intralesional therapies, we are using combination therapy with efficacy, trying to get that synergistic effect. So as Dr. Mills pointed out, I'm certainly a big proponent of collagenase. It is the only FDA-approved option here in the US. I would support the idea that if you took an average patient who meets criteria for collagenase and you were able to give him intralesional Verapamil or collagenase, on average, he's likely to have a slightly greater reduction in curvature with collagenase. And this is based somewhat on anecdote, although I think many in the audience would agree with that statement. And limited clinical evidence. Really, the only trial I could find was a recent publication from Eric Chung where patients were randomized to Verapamil versus collagenase, and this was an open-label, non-blinded study, but the average curve reduction was 17 degrees for Verapamil and 28 degrees for collagenase. But remember, not every patient in your clinic with Peyronie's is a nail and Xiaflex is our hammer, right? We need to take a more nuanced approach. Let's think about that. So the FDA-approved medication package insert says patients need at least 30 degrees of curve. How many in the audience have seen a patient who has less curved than 30 degrees that we measure objectively, but is severely psychologically bothered. And this is especially true, at least in my practice, for our younger patients. We also see patients who have more pain predominance or more indentation predominant, so less severe curvature, but other symptoms. The studies with Verapamil and Interferon have both shown the expedition or resolution of pain in 60 to 90% of patients, compared to essentially no change in pain, and in my experience with collagenase, maybe an increase in pain, at least in the short run. The other thing is we're giving a large volume of medication. We're doing that mechanical fracturing of the plaque with collagenase, so when you have more indentation predominance, you have a larger plaque. Maybe we're able to get better outcomes with respect to indentation. He also mentioned side effects, and yes, collagenase is associated with local side effects. Intralesional therapy with Verapamil and Interferon may have more systemic side effects, but really, these are pretty significant local side effects for our patients. This is Dr. Mills's own publication from earlier this year. I think those of us who do a lot of collagenase have seen variations in all of this: hematomas, necrosis, even that dreaded corporal rupture. The other thing is we're telling patients, you cannot have sex for 4 weeks. And if the ultimate goal with this is trying to get patients to better sex, that's a hard pill to swallow. Also, if you put that in the context of roughly a sixth to a third of patients don't have any significant reduction in their deformity, whereas, I'm going to skip over this, whereas with Verapamil, the side effects are a little bit more tolerable. We don't recommend against sex for multiple weeks, so maybe this is, again, an easier process for patients with less severe deformity. Not going to get into a lot of detail, but cost is a big consideration. Yes, here in the States, many insurance plans cover intralesional collagenase, but we're stewards of healthcare expenditures, and so offering the right therapy to the right patient and thinking about costs is important. And finally, for our colleagues outside of the US, this is Sexual Medicine Society of North America, so not just the US. This isn't always available. So in conclusion, who's that optimal patient? I think it's the patient with predominant pain, who has less severe curve or maybe more predominant indentation deformity. Even Dr. Mills, I've heard him argue multiple times that even if you don't get an objective change in the curve, maybe softening that plaque makes sex easier. Those patients who are concerned about side effects, looking to continue to engage in sex despite pursuing treatment, don't have good insurance coverage, and ultimately just want to do something more than observation or traction. So here's Dr. Mills. He's got his fancy new tool belt with these FDA-approved options. But remember, Dad's old toolbox is in the back of the garage, and sometimes we just need to pull out that old, screwdriver or that old pliers to get the job done. Thank you.